Hello and welcome to the Parkinson's Foundation Let's Talk About It Symptoms Beneath the Surface program. I'm Melody McLaughlin, Senior Community Program Manager for the New England chapter of the Parkinson's Foundation. I'm thrilled to bring to you the Parkinson's Foundation's first official community education program based in New Hampshire. I must admit we imagined our first New Hampshire program looking a little bit differently, but maybe some of us would have taken advantage of this glorious New England weather by sneaking in some leaf peeping either before or after our event. But nonetheless, you've made it, and we're so glad you did. You are not alone, and your Parkinson's community is here with you from near and far. For those of you who are newer to the Parkinson's Foundation, welcome. We are the nation's leading community for people with Parkinson's disease, the people who love them, and all those who are working to end the disease. With our presence in communities across the country and the globe, we believe in a promise of a cure and a better life today for those impacted by Parkinson's. The urgency of our mission really translates into what we do. To achieve our mission, we pursue three goals: ensuring better care for everyone for today, understanding Parkinson's through research for tomorrow, and educating and empowering the Parkinson's community for us all. We provide free resources, including our website, parkinson.org, educational book series, webinars, podcasts, our hospital safety kit called Aware and Care, our newly diagnosed kit, and of course our toll-free helpline, 1-800-4PD-INFO, which is staffed by Parkinson's specialists. And on the research front, we invest more than $10 million annually to study Parkinson's, what causes it, how to treat it, and ultimately how to cure it. I'd like to highlight PD Generation, which is an initiative that offers genetic testing and genetic counseling at no cost for people with Parkinson's disease. After a successful pilot program, we are thrilled to announce that the PD Generation study has launched its next step, a genetic test that can be completed at home. To learn more, visit parkinson.org/PDGeneration. So how are we connecting with our communities? Your being here with us today is a prime example of that. It's really through our centers of excellence, local chapters like ours in New England, volunteers, advocates, and staff across the country that we are able to bring people together to educate and empower those impacted by Parkinson's. We also connect with our Parkinson's communities through our nationwide Moving Day events. Since 2011, our Moving Day walks have raised more than $27 million to support research, our Centers of Excellence network, and provide education and resources and programs across the country. We're very excited to share that we'll be bringing a moving day to New Hampshire in the spring of 2021, so stay tuned for that. To learn more about our moving days, please visit movingdaywalk.org, or to see our recent virtual moving day in Boston, visit movingdayboston.org. And while we're always looking for ways to keep the PD community connected, the Parkinson's Foundation has been providing weekly educational and wellness programs in a virtual format through our PD Health at Home series. Join us at an upcoming Mindfulness Monday, Wellness Wednesday, or Fitness Friday by visiting parkinson.org/PDHealth. And last but not least, before we kick it off, today's program was made possible by the support of our sponsors. Today we thank our silver sponsor, Kiowa Kirin, and our bronze sponsors, Lundbeck, Supernus Pharmaceuticals, Medtronic, and Boston Scientific. Their ongoing support allows us to offer this unique opportunity to stay connected virtually and to hear from local experts. We invite you to learn about all of our program sponsors by visiting our virtual exhibit hall at parkinson.org/New England/chapter supporters. It is now my pleasure to introduce our speaker of the day, Dr. Enis Hannoun. Dr. Hannoun is a movement disorder specialist in the Department of Neurology at Dartmouth-Hitchcock, Manchester. He completed his MD at the University of Jordan and his internship at Englewood Hospital and Medical Center in New Jersey. Dr. Hannoun joined Dartmouth-Hitchcock in 2018 after completing his neurology residency and then his movement disorders fellowship at the University of Massachusetts Medical Center. He is a member of the Parkinson's Disease and Movement Disorders program at Dartmouth-Hitchcock and is clinical assistant professor at the Geisel School of Medicine in Dartmouth. Without further ado, please join me in welcoming Dr. Hannoun. Dr. Hannoun, you are free to share your screen and take us away.
All right, thank you, Melody, for this introduction. Very nice. I'm going to share my screen right now. And it is my pleasure to talk today to everyone here through the Parkinson's Foundation. Appreciate the opportunity. We have a lovely community here with the Parkinson's disease in New Hampshire, and it's my pleasure to talk to everyone today about this topic, which I always believe is one of the most important topics in Parkinson's disease. And education and knowledge is power. So learning about symptoms of Parkinson's disease is absolutely a key to, or a door to know how to manage those symptoms, either by the patient or their beloved ones and caregivers. So the talk, as we all see it in the screen here, let's talk about it, because obviously this is not the first thing that comes to the mind of the patient, their caregivers or the doctors, to talk about, which are the symptoms beneath the surface. We tend to have a different name for this in the medical community or in the movement community, particularly we call it the non-motor symptoms. And why do we say the non-motor symptoms? By the way, I'm going to proceed with my slides, and to proceed, I was just like, my first slide is that there's no disclosures, no affiliations with anything that's related to this lecture today. So to begin with our goals from this lecture today, we would like to have a deeper look into Parkinson's disease presentations. And again, as I said, what we call these symptoms beneath the surface, or the non-motor symptoms, are one of the presentations of Parkinson's disease, and understanding where they come from, just another way to stabilize and remember those very well and how to deal with them. And in addition to that, knowing some of the methods and approaches to manage those symptoms. And as if you will see, my goal is to share with everyone here how to manage those symptoms initially by avoiding trying medications as soon as we can. By understanding those and knowing where they come from, and know the way how to at least try to manage them without medications, that will be a great success or a great start. So let me move on here and talk about the symptoms of Parkinson's disease. So we all know about the symptoms of Parkinson's disease that first comes up to the surface, which we call what we call the motor symptom. Remember, I told you that we call those symptoms beneath the surface the non-motor symptoms. You can alternatively use the word moving symptoms and non-moving symptoms. So the moving symptoms is what we are familiar with. They are the four, we know them as the four cardinal features. They are the tremor. Of course, a lot of Parkinson is not similar in every single patient, and it's like a spectrum. And we put the spectrum based on those symptoms we're seeing in front of us, which are the tremor, the slowness in movement. We also have a different name for it called bradykinesia, postural instability or walking difficulty, and stiffness. Basically, it comes down to those four features when we want to diagnose Parkinson's disease or talk about the motor, like we said, or the movement symptoms. Now, again, the spectrum is different, and some people will have all of those. Some people will have only some of those. Like you will see a person who have only tremor, and that's their most bothersome symptom, and barely have any of the other three. The opposite is true. You'll see someone who has balance difficulty, or maybe difficulty with the slowness and dexterity, and they barely have any tremor. So those are the clear symptoms to us, or we see in front of us, and we confirm the diagnosis. And we actually follow treatment based on those symptoms. However, the other symptoms of Parkinson's disease, and that was just only the first line, if you see it. The second line is non-motor symptoms, and those are the symptoms beneath the surface we're going to talk about. We also deal with a good amount of what we call complications of Parkinson's disease. It's not necessarily a primary symptom of Parkinson's disease, and it's not necessarily a symptom beneath the surface, but it is a complication. We are not, it's outside of the scope of this lecture to talk about complication. Just a simple example that a lot of people are familiar with, dyskinesia. We consider that a complication. Now, medication side effects, also something that Parkinson's patients could also complain about. And for example, we mentioned the very most common nausea that sometimes people complain of after starting the medicine. So nausea is not a Parkinson's symptom, obviously. It's a medication side effect, and many others could be like that. We're going to talk about one important symptom or a complication of medications at the end of the lecture. Now let's move on here, and as we said, we're going to focus today on the non-motor symptoms. So the non-motor symptoms, this is a complicated diagram, but what I want you to understand from this, I hope that you see my cursor here, the arrow moving. What I would like to tell you that this is a time, these are the years. The x-axis, it represents the years, okay? And look at the years here. Here, 0 is the time of the diagnosis. This is when people get diagnosed. And how do they get diagnosed? The motor symptoms. Here, when the tremor starts, the slowness starts, or when they get balance difficulty starts. Here in the middle, what's happening before? 10 years, 20 years before. We have what we are going to talk about, which and they keep going. It's not that they stop here, but this is the beginning actually of the what we believe the beginning of the symptoms of Parkinson's is the symptoms beneath the surface. We call it beneath the surface because it has not been yet attributed or attached to a diagnosis, because it's general and people might think it's because of something else going on, like constipation and others that we're going to talk about. So as far as 10 and 20 years, symptoms can start, and then we're going to say, well, now that we know the diagnosis exists, probably we are dealing with some of the non-motor symptoms here. This is what this represents, in fact. And to many people, the non-motor symptoms are the major disturbing symptoms and the most burdening symptoms than the motor symptoms. And that we can see this in many cases where people just tremor is very well controlled, they walk fine, they're exercising, they're doing everything, and their medications are working very well, but they have some difficulties with their non-motor symptoms. This is an example. I'm going to just 2 slides. Those next 2 slides talk about the non-motor symptoms, and here they are in the order we are going to talk about them. And I encourage people in the audience right now, if they are, I mean, it's not a must. You can just like sit back and enjoy our talk. But I encourage, if someone is interested about one thing that they kind of like, maybe, well, maybe this is what's going on with me, for example, or a caregiver or a family member, they can write down, take notes. We're going to share a lot of pictures today, just make it easy for us to deliver the idea. But if you want like just to take notes about this particular topic or note, then you will be able to refer any slides in the future. If you have access to them, you say, okay, well, this is what we talked about when we were in the lecture. So here, constipation and anxiety and depression, overactive bladder, REM sleep behavior disorder, we're going to talk about that, orthostatic hypotension, fatigue, cognitive impairment, hallucinations, sexual dysfunction, restless leg syndrome, swallowing difficulty and drooling, insomnia, difficulty sleeping, and hypersomnia means people are sleeping more, and anosmia. Anosmia is the lack of sense of smell. And we have one more I did not include here. We're going to talk about it. It's called rhinorrhea, the runny nose. Now, I will proceed with talking about constipation. So constipation, I like to start with constipation because it is one of the earliest signs. And I'm going to make a note here that many of those non-motor symptoms are general symptoms, and people could have them because of other conditions. It's not necessarily that this is particularly caused only by Parkinson's disease. For example, constipation is a really common problem. It can happen because of many other reasons. The way we think about those symptoms when it happens in Parkinson's disease is that it is possibly caused by Parkinson's disease, or if not, it is maybe an overlap with something else. For example, someone on a medication that causes constipation, someone is maybe having difficulty moving because of other reasons, you know, mobility, lack of mobility causes constipation. Some other people have some surgeries in their guts. And so those symptoms are not only restricted to Parkinson's disease, but definitely if they exist in Parkinson's disease, we pay more attention to them. So constipation, why would constipation happen? We know that constipation is controlled by the nervous, the bowel movement is controlled by the nervous system. And it's controlled by one type of the nervous system. It's called the autonomic nervous system. Autonomic, remember the nerve, you know, we have sensory nervous system, and we have the motor nervous system. We have the autonomic nervous system, and that's the one that we do not have control over. It's from the term auto, I mean, it's automatic. We do not really control. So the autonomic nervous system controls a lot of the functions in our body that we do not have control over, like our heartbeat, our bowels, esophagus, swallowing, breathing. So Parkinson's disease, in the majority of those non-motor symptoms, tends to act through the autonomic system and affects those nerves. And constipation is one of the consequences. Some people will have actually an alternating constipation and diarrhea. And that's kind of like a second step after constipation. Most people will deal with constipation. It's not everyone's problem in Parkinson's disease, but I would say it's one of the most common. Why do we care about constipation? We care about constipation because one of the important factors that allow the medicine in Parkinson's disease, I'm sure a lot of people by this time in the audience know about levodopa or dopamine agonists, and all those medications count on the bowel movement for their absorption. So whenever there's constipation, our judgment of the medication effect on our bodies is lacking. It means that we do not know exactly if there's any we do not know the true benefit of the medication in our body. So that's why I always like to make sure that we understand this point, because before making drastic changes on our medication, we would like to look into the management of constipation. If there's any constipation before, let's say people start like, okay, well, I have tremor more, maybe let's increase my medicine, let's change the way we're doing it. But while there's difficulty in absorbing the medicine, this is a different story. Now, what do we do about constipation? This is my next slide. A lot of things, and I always send people with a list of those things to pay attention to. We know by default a lot of them, but we don't always necessarily adopt them as a life project. Like hydration, for example, exercise, And I'm gonna just use the cursor here to point out to the picture that talks about certain things. So hydration, make sure that we are hydrating during the day. That's a key factor in a good loose bowel. Exercise as well. We know that sitting down for long hours or like for days and not moving too much causes constipation, even with people without Parkinson's disease. Some people suggest probiotics helps the guts, the bacteria in the bowel to digest more, to dissolve and help with the digestion. The diet, fibers, include a lot of fibers, avoiding too much oil and too much like pure protein, and that will be something to consider. Always have the, people love the prune juice and all those like magical recipes. Education, knowing about this and maybe seeking the right medical attention. Sometimes we work side by side with gastroenterologists to help us with the advanced cases. Of course, that would lead sometimes to endoscopies. That's with the advanced cases where we're lacking the possible management methods. And stool softeners, and we are lucky to have a lot of the non-chemical stool softeners over the counter that are not necessarily, they're not prescriptions. And sometimes I feel people are not too generous with those, although I feel that if there is anything that could be used and they're less chemically or less industrialized, and that's the way to help a symptom that is very important in Parkinson's disease. So let's move on here. And by the way, we know that Melody has probably said about the question part at the end, but we're going to take questions. You can divert your questions to her. Let's talk about the following non-motor symptoms, which is mood in general. Mood is important in Parkinson's disease. And when we talk about mood, we always talk about two set of causes here. The mood that is a reaction to the symptoms itself means that, someone's just not walking or maybe having difficulty in balance, or maybe their tremors bothering them, or maybe their motor symptoms basically is bothering them. They might feel upset and they might feel sad. They might feel anxious. Now, and the other set of symptoms basically is something that has nothing to do with the surrounding, with the external surroundings. It means that it's not necessarily because the symptoms are bothering the patient or they are sad about the symptoms, but it is just a part of the presentation of Parkinson's itself. So we should not necessarily ignore those feelings and think about, oh yeah, okay, well, probably I'm sad or upset or anxious or stressed out because of my symptoms only. That's true for a big part of the mood disturbance that happens in Parkinson's disease, but also we could face like what we call it primary mood difficulty in Parkinson's disease. And that what takes a collaboration from the family and the beloved ones to recognize that this could be part of the non-motor symptoms. And we know scientifically and pathologically, this is part of the chemistry that happens in Parkinson's disease, where we're the center in the brain that controls the dopamine also has overlap with some of the chemicals responsible for mood, like serotonin. And that's where the belief exists that mood simultaneously could happen, or mood disturbance could happen in Parkinson's disease. Just if I am not, those symptoms are not a must in everyone, by the way. A lot of people have no mood disturbance at all, no constant. We're not implying that everyone should or may have those symptoms in the future. We're talking about if you have any of those symptoms, that this is the way. But otherwise, I know a lot of people without mood disturbance at all. What do we do with an anxiety? Anxiety is a multimodal, kind of like something that you have to approach from many aspects. One of the important things that I always talk to people about is mind over body. And I actually learned sometimes from some of the patients I saw on how amazing they did only by implementing the methods of mind over body, mindfulness, meditation. Some of them will do yoga, relaxation exercises, breathing exercises. Amazing, powerful tools. Always suggest that to people. Whether you believe in the spiritual part of it or not, that always, even the physical part of it, is proved to be helpful. The way to do this is by dedicating the time to do it, because it makes a difference. We never dedicate time to something non-physical. We always dedicate time to take our medications, maybe to exercise, maybe to do some work. When it comes to the non-physical part, that does not include a reaction, a direct benefit, we always, and including everyone, we always spare that. Exercise. Exercise is one of the things that has been proven by research. About a few years ago, they've ran a huge study about exercise and its role in even preventing any mood disturbance and Parkinson's disease. And it was positive. It was positive, and those who exercised did much better in their mood. I know that exercise in general makes you feel happy, and all the good feelings surge when you do it, but that's not the situation here. Exercise actually was in isolation of those played a role in limiting or decreasing the mood disturbance in Parkinson's disease. Sleep. A lot of people have difficulty with sleep. We're going to talk about this in a bit, but sleep also affects the mood. So if someone having difficult, like increased stress and anxiety, we understand that could be Parkinson's disease, could be they're upset about the symptoms. But if you're not sleeping well, probably you need to pay attention to that as well. Of course, eventually the support around us and the knowledge about the symptoms is very important. Whether it's from the family, whether it's we elected to go to a counselor. The counselor is not some people look at the counselor as a stigma or something for life. And I always say, use the counselor to the best that you can to lift you up to a place where you can just take over and be on your feet with your doctor, whether you're taking medications or not. So a counselor to help out with some of the stress reduction methods and cognitive behavioral therapy. Of course, eventually medications are also used to help, and they sometimes we always, sometimes we have no other way around, but it's not alone. You shouldn't be counting on medications alone. You should count on your own tendency and ability to get better. One of the important things about mood is that I did not hear specify is apathy. I always tell people and their beloved ones and families, apathy is a lack of expressing emotions. And it's something we see sometimes in Parkinson's disease. One of the things that could be taken the wrong way from the other person, and we always ask people to educate family members, beloved ones, those who are really close, that apathy or lack of expressing emotions is maybe part of the presentation. It's not intentional, so don't take it personally. And that works in a good and positive way. Most people, if not all people, are well receptive of the idea. I'm going to jump to another good, important topic, which affects other aspects of Parkinson's, which is the overactive bladder. If you see here, like the bladder is surrounded by muscles that squeeze the bladder and muscles that squeeze the sphincter. So when the urination happens, the muscles squeeze the bladder. When the urination stops and you want to stop, or you don't want to go, or you're sleeping, the sphincter contract, the muscles around the sphincter constrict. And that's controlled again by something we talked about before, autonomic nervous system. So this is another aspect of the autonomic nervous system. So what's an overactive bladder? Overactive bladder is the muscles around the bladder itself is just doing it too much, more than it's needed. And that will result in the frequency. People like to go to the bathroom more often during the daytime and sometimes during the nighttime. Accidents might end up being happening at some point. Waking up during the night happens to go to the bathroom. That brings up a whole different issue with many other things. Disturbance of sleep, and we saw what sleep could do to, and difficulty walking to the bathroom. So looking at this issue here is very important because it might be connected to many other things. Because lack of sleep, we can talk about it. This is like a kind of like a central thing about many things. Fatigue, mood. So sleeping at night is very important. One of the major contributors to lack of sleep is overactive bladder. So what do we do about overactive bladder? Now you see this glass of water here where it looks like it's night about it. This is what I always tell people to avoid. Taking lots of fluids in the second half, or maybe after 6 p.m. or in the evening, or maybe in the last 4 to 6 hours before going to bed. Hydration is very important in Parkinson's. We always encourage people to hydrate. But just to avoid that later part of the night, would be beneficial to avoid inflating the bladder during the night. Look at the picture next to it. You see this person having their head of the bed elevated by 30 degrees. Now there's a semi-complex, I would say not too complex, pathophysiology behind this mechanism, or how this is going to decrease the ability for people to go to the bathroom too much when you sleep. Now, this is not always convenient for people because, sometimes people are sleeping next to others and they don't want to disturb them, but this is one of the things that could be done, and it decreases the pressure in the kidneys, and the kidneys will perfuse less. You see the picture behind this, you see this guy with a yellow shirt and gray pants. This is what we call current exercise. And this is what a lot of people, a lot of women who had pregnancy know how to do it or know about it. Always the spouse or the patient, if she's female, she knows about it because this is the way used. It's the physical way to strengthen the pelvic floor, and this will help not letting too much urine out. I've had people who told me this is all the only thing that helped them, and this is all what they needed to do to help them controlling the overactive bladder. I'm not sure, like there are different degrees of this, and some people might need more than that. But if you were having some mild symptoms, you might want to look at this exercise. And also, before going to bed, always empty the bladder, and eventually help from a urologist might be needed, and medications might be helpful as well. I always say we start always with a non-medication part and see what the medication could help with at the end of this. I'm going to move to another symptom, which is a very important symptom of Parkinson's disease. It's called REM sleep behavior disorder. Now, this is one of the least recognizable symptoms in Parkinson's disease. We know that sleep is divided into REM and non-REM. REM is the one where people having dreams. What happens in Parkinson's that during REM, when we're sleeping, we're paralyzed. Actually, this is one of the physiologies that the body does to our body, to us, or the brain control over the body during sleep, and REM sleep, it paralyzes the body. Because if you're not, you're going to act up your dreams. And this is what happens in Parkinson's disease. People sometimes act up their dreams because they're not totally paralyzed during REM. whether it was by dreaming vivid ones or moving during the dream, sometimes really aggressive movements, sometimes if it's really aggressive, flipping off the edge of the bed, talking out loud. So many people will say, we'll call this names, different names, which is like hallucinations or restless leg syndrome. They will call it a lot of names, but this is basically a REM sleep behavior disorder, one of the most common non-motor symptoms of Parkinson's disease. It could be bothersome to the person sleeping next to the one who is having them. Less bothersome to the patient themselves most of the time, I would say. So recognizing them here, aha, we know about it now, we know what's going on now. Understanding and asking the spouse or the person sleeping next to us, do I do that? Because most likely, as I said, people who's having this, they don't really know. In severe cases where people are falling because of the REM sleep behavior, sometimes ask for some bed rails or maybe sleeping on the inside of the side of the bed that's, facing the wall, if that's the situation. Before starting any medication, I always tell people to try high dose melatonin. Melatonin is not a sleeping pill necessarily. It's a medicine that will adjust, or I wouldn't call it even medicine. It's a hormone that exists in everybody, but it's stimulated by lack of light and noise. And we, in our society these days, we have a lot of noise and light, even at night. So the melatonin stimulation is not too helpful. And getting it externally through taking a tablet could be helpful. High dose is the one that we always talk about, not the 1, the 3. We always talk about 5 milligrams and higher. Some people takes up to 15 and 20. Safe. Take it not too late at night. Give it some time for it to work. Don't expect, oh my God, I took melatonin tonight, I didn't have a good night's sleep last night, it's not working. This doesn't work like that. It adjusts the cycle. You want to give it a week or 2 weeks at least for the body. It's like a jet lag kind of thing. All right, so I'm going to move on. Okay, so orthostatic hypotension. This is very important. Always ask people. It's not. This is a common symptom. Some people don't have this at all. Some people have it partially, and sometimes it's very, very severe and disabling. And this is known as one of the most disabling symptoms of Parkinson's disease. And some of you who have this and have it really severe know what I'm talking about. And it's not, we sometimes struggle navigating through multiple options. We have a lot of options to manage orthostatic hypotension. Sometimes it requires really aggressive measures and a lot of thinking and planning. And still people will have difficulty with their dizziness. And that's basically happened because of the drop in the blood pressure when people get up really quickly, or even without getting up really quickly, even by standing, they will have lightheadedness, and that will affect their balance and sometimes their cognition and speech. So, so that's what orthostatic hypotension is about. What do we do about orthostatic hypotension? Remember this picture of the person who's sleeping with the 30-degree elevation of the headbed? That is one of the ways. We talked about this for the overactive bladder, and for the same reason, decreasing perfusion in the kidney preserves all the fluids inside the body and prevents some of this feeling in the morning when people get up and start walking around. This picture here, getting up slowly, practicing getting up slowly is very important. Some people, especially in Parkinson's disease, get up quickly and they just want to get up and go. That we need to train ourselves to avoid that in order to avoid the trigger of the orthostatic hypotension. Salt and water, as we said, hydration is very important. Unlike most of the cardiologists, and if someone probably talked to their primary care physician, they discourage people from this here in the right. They said, oh, decrease your salt in your diet. We know that. We know that about to a certain degree. Of course, if you're having the issue with orthostatic hypotension, you want not to dismiss salt completely. You want to maybe keep a little bit, because this is one of the factors that the body maintains fluid because of how much salt in your body. If you have a high blood pressure issue or heart issue, yeah, you want to listen to your doctor, but also talk to them. Tell them, I have this orthostatic hypertension. What do you suggest? The maximum I can have. Look here on the right. This is one of the very important measures of orthostatic hypertension treatment. I know it's one of the things that patients are least compliant with, wearing compression stockings. It helps squeezing the circulation in the legs into the body. Many people notice the difference right after starting using it. The other option is abdominal binder around the belly. We are running a little short of time. I'm going to move on, but these what we talked about is very important here. This is ankle compressions, of course, squeezing your ankles and calves before standing up and making a hand grip helps as well. Eventually, medications. We end up using medications sometimes. Hallucinations. Hallucinations are not everyone's experience. We understand that. And they're not necessarily everyone's experience, like upcoming experience. So they happen in degrees. The most important factor, or the most important sign of hallucinations in Parkinson's, that people most likely know about hallucinations when they happen, and they are not foreign to them, and they are not disturbing to them. This is the most common scenario. Many people actually do not elect to do anything about them because they know how to deal with them mentally. Unlike hallucinations and other conditions where people are in total belief. Now, this could happen in Parkinson's at later stages or when there is some other things going on. Basically, this is a plus when hallucinations happen in Parkinson's disease, which does not necessarily require that we treat them right away. What do we do? So look here, we said that monitor with this magnifier glasses, just monitor them. See if they're really causing disturbance or not. As long as they're not causing disturbance to the patient or the surroundings, as long as they're redirectable, people are believing their beloved ones, their caregivers, okay, well, they're not there, so that works. That we don't have necessarily to do any drastic measure. Decreasing some of the medications that causes hallucinations could be one of the things we consider, but most likely those medications help the movement in Parkinson's. It's a catch-22 sometimes. We try to have good balance. Any hallucinations that happens, and here I'm pointing at what's called delirium. It's important for us to know. Delirium is hallucinations that happens in an acute settings. Means someone got into the hospital, been in the hospital for a week or two for a urinary tract infection, pneumonia. They fell and broke a bone, and they stayed in the hospital, in the rehab center. There could be a hallucination part. Now, this is not necessarily the Parkinson's getting worse, because these hallucinations, or what we call delirium, could happen to anyone, whether they have Parkinson's or not. So a lot of people jump into big conclusions that we're going to make some changes, medications, permanent medications, decrease, and always think of, okay, well, let's see how can we manage this outside of the thought that this is a Parkinson's first, and then maybe if not, we can consider changes. Of course, eventually, what we call antipsychotics, they're great medications and safe in Parkinson's to use. We try to use them eventually. So a big part in the family and the surroundings to help with the hallucinations, understanding what we're talking about now. dementia and cognitive impairment. Again, these are not necessarily a must to happen. A lot of people really do not experience any cognitive impairment. Some people might thought slight slowing or difficulty with multitasking, as we say it. That's maybe the most that some people have, and sometimes it's severe enough to be called dementia. There's no rule who gets that or who gets this, but we always talk about things that were done in research. You look at this muscle, the brain holding a muscle. The brain actually, training the brain or stimulating the brain mentally is like training a muscle. Keep the stimulus, your brain will preserve a lot of the functions and will strengthen them. Decrease the stimulus, decrease the exposure to beloved ones and the social circle, maybe sticking to a routine might not be what's helping the brain actually. Of course, to a degree. For people who have severe dementia, you don't necessarily need to do a lot of stimulus because that might be reflecting on them negatively. Now here, exercise, let me talk 2 seconds about exercise. This is proven by research. Again, they ran this study a few years ago. They ran it on both exercise and mood. If you remember, we talked about the mood, and they said that exercise prevented and helped both preventing cognitive impairment and mood disturbance. Hydration, of course, always good for the brain. Brain cells has a lot of percentage of fluids, so hydration is important. Let's talk about this restless leg syndrome that people most likely are familiar with and they experience sometimes. Now, this is not one of the most common. This is not actually too common, but it happens. People get this. And it's the sensation of internal unease or crawling sensation. When you stop moving your legs, mostly happens towards the night and goes away with moving the legs. Why it's happening in Parkinson's, not really understood the connection between this and dopamine, but it responds to dopamine treatment. But before that, we need to check on things. And this is important for us to maybe rule out or decrease stimulants like maybe caffeine, at least towards the midday, because caffeine could make restless leg syndrome worse. Iron, measuring the iron is very important because before we start thinking about any cause of restless leg syndrome, your iron storage in the body has to be high enough, because low iron is always attached with restless leg syndrome, and that might be the only thing needs to be fixed. Exercise always helps. This machine here on the right side, pedaling, I always ask people to get it, the one that comes under the legs, while they can do it while watching TV and the time where actual restless leg syndrome happened. So pedaling machine, very affordable financially. Insomnia could cause this restless leg syndrome. So maybe talk to your doctor about the lack of sleep, which might help restless leg syndrome. Some medications could cause restless leg syndrome, so we want to navigate through those with our doctors. And eventually, as I said, dopamine help it. Like in Parkinson's, some of the medications we actually use for treating Parkinson's could help restless leg syndrome itself. I'm going to move into fatigue. Fatigue is the sensation of tiredness, and that happens during the day. Okay, thank you. They're telling me that. Okay. I will probably talk about fatigue right now, and we will be fulfilling most of what we wanted to talk about, and then we can take questions. I know a lot of topics here and a lot of information, but very people are familiar with a lot of the terminology and the topics here. But whatever we didn't talk about today in the list that I presented initially will be available in the slides if someone wants them. So fatigue is very multifactorial. It happens because of many things that happens in Parkinson's disease, but could be very independent of everything else. like isolated fatigue, just the inability or the lack of power and energy. So what are the things, and this is important, what are the things that causes fatigue? So starting from the mood, depression and anxiety could cause fatigue. Insomnia and difficulty sleeping could cause fatigue. Lack of exercise could cause fatigue. Lack of ability to move could cause fatigue. And as I said, it could be just an isolated symptom. I have probably a few others that I connect to, probably not in my, did not pop in my head right away. But let's see here. So diet. A lot of people who in Parkinson's have trouble maybe sticking to a certain diet or regular diet. Some people loses weight, and this is another cause of fatigue. Lack of exercise. In Parkinson's disease, exercise, unlike fatigue in other places, helps fatigue. So people have it generates energy for people and overcomes fatigue. The common thought that if I exercise, I'll be more tired, but in Parkinson's, actually, it's believed to be the opposite, unless there's a fatigue from somewhere, something else. Napping during the day. Also, people nap. Napping is a very healthy habit for everyone, basically. But specify the nap. Say, I want to nap in this particular hour, 30 minutes, an hour, and that's it, before and after. Caffeine, unless it's prohibited or not desired. After the nap, in the midday, in the morning. Sleep. Imagine someone having difficulty sleeping, so they will feel fatigued, not because of Parkinson's, just because they're not sleeping. Some of the medications could cause fatigue, and unfortunately, in rare cases, medications for Parkinson's disease could cause fatigue and tiredness. Eventually, we can do some medications for fatigue, but that's little less after we fulfill all the things. So I know we have more to talk about in Parkinson's disease, but I will stop here and I will take questions from everyone. I'm sure that Melody has gotten some questions. Sorry to go over the time a little bit.
Just fine. I'm so glad you covered fatigue because we do have some questions about that. And thank you, Dr. Hannoun, for sharing this information and this fantastic and wonderful presentation. As I mentioned, we do have a few questions from our web audience today. Very engaging audience. Mm-hmm. What can help with apathy? Are antidepressants helpful?
Yes, so antidepressant could help with apathy, definitely. Now, when apathy happens, it could be resistant. It's not like the depressed mood. It's a little more than that. There is a way to, we advance the treatment with antidepressants. And if there's any, if it's refractory eventually, there are tendency for the psychiatrists and some neurologists to add a stimulant for the apathy. But education is the most important thing. Education. A lot of people, you'll notice a lot of people with apathy, you'll ask them, are you sad? They'll say, no, I'm not sad. I'm not anxious. And they have basically nothing to express their feelings or what's happening with them. So that's just an external perception of what's going on. So yes, there is treatment. Antidepressants could help in the beginning. If those who do not respond to that, maybe some tweaking of the antidepressant or addition of some stimulants could help. If it's causing trouble, of course, sometimes people just live with it.
Great, thank you, Dr. Hannoun.
You're welcome.
Could you comment on gastroparesis and its influence on absorption in Sinemet, and also maybe explain to others what gastroparesis is?
Gastroparesis is the lack of movement of the bowel movement. Or lack of movement of the bowels, basically. So, as I said, the autonomic system is affected in Parkinson's disease, and the bowel movement is controlled by the autonomic system. Now, is this contributing to lack of absorption? It is, yes. Now, it depends on where the gastroparesis is happening. If it's in the bowel, and that's what we call basically constipation. So we have methods to deal with that. If it's in the stomach, which is way less common, you don't see that too common, and you don't see it necessarily with the average Parkinson's. You see it with a really advanced and extreme Parkinson's disease. And those have also other treatments for the gastroparesis that will stimulate when we talk about the stomach and the small intestine before reaching the large intestines. So yes, it does slow down. What slows down most is the constipation. Basically, that's the most of the focus goes on that. But yes, it does slow down the absorption.
Right. Our next question here, are hallucinations a non-motor symptom or a medication side effect? If I reduce my meds, does that help with motor symptoms? Does that mean those meds cause the hallucinations?
Very good question. It's both, but it depends, you know. It's like, as I said, catch-22. Because hallucinations are are not always disturbing or severe, we always say, okay, we're going to compromise here. We're going to deal with those hallucinations because decreasing the medications might result in more tragic outcome, which is, let's say, falling or more tremor. So they are both. But the hallucinations could happen without medications in Parkinson's disease. Medications maybe let them happen more or allow them to happen more. But it's not only side effects of medications. People who are not taking medications at all did experience hallucinations. Lowering the medications is a solution to the limit where it could be taken, or it could be tolerated, because lowering the medications too much might result in worse symptoms than hallucinations.
Okay. I have been punching my husband in the middle of the night. What is the solution? We do not want to have separate beds.
And that's what I talked about. Remember the REM sleep behavior disorder. This is the first thing that comes up. Punching my spouse, punching my husband, punching my wife. And as I said, knowledge is a key. And starting with the melatonin, high dose melatonin, give it some time. And if that doesn't work, then maybe a more faster intervention should be done. There are lists of medications. Every doctor usually do this in their own way, but according to the guidelines, we like melatonin because it's kind of considered non-chemical, kind of like it's natural. But afterwards, there are medications that could serve other purposes. Medications that could probably help with the mood, could stop this REM sleep behavior disorder and punching at night. Medications could help with losing weight could help with this. Medications could help with insomnia, could also help with the REM sleep behavior disorder. So there's a list of medications. We're not we don't have time to talk about all those medications, but there are solutions that are stronger than melatonin, could be tried in case of failure of melatonin.
Great, thank you. And I have a few questions here about urinary infections and sort of urinary urgency. Is there a connection between urinary infections and PD? And does my SINMET sometimes associate with urinary urgency?
Not really. I believe the answer is no to both of those questions. The urinary tract infection is not one of the symptoms of Parkinson's disease. And usually overflow of urine is a protective mechanism of urinary tract infection. So actually, urinary tract infection can happen when people having retention, which is the opposite of what happens to Parkinson's. So not urinary tract infection. SINMET does not really contribute to either urinary tract infection or the frequency.
Great, thank you. And I think we have time for just 2 more questions really quick. And for anyone whose questions weren't answered, please call our specialist on our helpline at 1-800-4PD-INFO. But Dr. Hannoun, how can I control fatigue and wanting to sleep constantly?
Okay, as we said, fatigue is a very multifactorial process. if you have the slide of the fatigue, kind of like put this here on top and say, okay, am I exercising? Am I napping fixed times a day and in the day? Is my fatigue connected to taking the medications? This is a really important question, because sometimes in rare cases, cinnamon could make people a little tired, but it's most likely the opposite. Usually cinnamon is energetic. So looking at those factors, am I doing this? Am I sleeping well during the night? Am I eating well? Am I losing weight? So if those all are well controlled and every one is check mark, then probably where you're dealing with the primary fatigue, means that this isolated fatigue that happens as a non-motor symptom. For that, we do have some options in treatment of Parkinson's disease, like amantadine and selegiline and a few others. But there are some solutions in case we manage the surroundings that I talked about.
Great, thank you. And one last question. I know we still have quite a few people logged on, so I'll ask it. What are the ways Parkinson's can affect vision?
Okay, this is an excellent question. The way Parkinson's can affect vision is not by affecting the eyes itself, because we know Parkinson is in the brain. It's not affecting the actual vision, means that I can't see very well. It affects the three-dimensional perception of vision, means the interpretation of vision. So people will be seeing very well, having 20/20 vision acuity, unless they have a vision problem from other issues in their eyes. But from Parkinson's itself, the three-dimensional interpretation of the things will make things look different than what they are. Imagine you're looking at a cloud, seeing a rabbit, or something like this. But this is common example that happens to everyone. But looking at a coat and seeing some maybe a shape of a face or something like that. So the disturbance of this three-dimensional interpretation makes it difficult maybe to for some people to walk, maybe to drive their car, maybe to park the car. Sometimes this is a common example. And again, there are some solutions. There are some, physical therapists are aware of that, and they do cueing therapy and therapy by reference. So that's the only way, and that's the way vision is affected in Parkinson's disease. Misperception, that's what we call it, a common thing by imagining something in the edge of the eye, imagining you saw something but you look, it's not there. We don't call those hallucinations, call those illusions, and they are, again, from the same concept or because of the same concept, different misperception or interpretation of the depth of things.
Wonderful. This Q&A segment does conclude our presentation, and on behalf of the Parkinson's Foundation, I want to thank our fantastic speaker, you, Dr. Hannoun, of course, Dartmouth-Hitchcock, and especially all of you joining us today. If your question wasn't answered, as I mentioned, I encourage you to please contact our helpline at 1-800-4PD-INFO, where our Parkinson's specialist would be more than happy to hear from you. For more information about our resources or upcoming virtual events, visit our website at parkinson.org, or for a local touch, visit parkinson.org/New England. And this program, as Dr. Hannoun mentioned, was recorded and will be archived on our YouTube channel, parkinson.org/YouTube, so you can refer back to those slides. Another round of applause and thank you to today's sponsors, our silver sponsor, Kyowa Kirin, and our bronze sponsors, Lundbeck, Supernus Pharmaceuticals, Medtronic, and Boston Scientific. You can learn more about today's sponsors by visiting our virtual exhibit hall at parkinson.org/New England/chapter supporters. And last but not least, we hope you'll come back soon. Our next virtual New England program is in collaboration with St. Elizabeth's Medical Center on November 6th, Parkinson's disease and special senses, vision, smell, and taste, which we sort of almost started to touch upon this afternoon with speakers from St. E's Neurology Department. You can learn more and register at parkinson.org/special senses. And then next up in our PD Health at Home world, on Wednesday, October 21st, is What's Your Parkinson's Story? Share It, followed by October 28th, Parkinson's, Shakespeare for Parkinson's. For a complete lineup of our PD Health at Home virtual programs, please visit parkinson.org/PD Health. And that just about wraps us up, folks. You'll receive a short survey. We hope you take a minute to complete it. We love to know what you thought and any other topics that you'd like to learn about. Thank you again for joining us from New England, Dr. Hannoun, Dartmouth-Hitchcock. Thank you from New England and beyond. Stay well and come back soon. Farewell, everyone.